Assalamu alaikum. Welcome back. We will continue our session. Our session now about Jordanian AHA experience in Chest Pain Center with Dr. Nail Ashobaki, Istiqlal Hospital.
السلام عليكم ورحمة الله. كيف ضويب؟ شباب شغال. السلام عليكم، مساء الخير جميعا. يعني أنا طلب مني نحكي عن الاكسبيرينس اللي احنا في مستشفى الاستقلال. كنا أول مستشفى قدمنا ابلكيشن للاي اتش اي عشان ناخذ شهادة الاي اتش اي سيرتيفيكيشن للتشست بين كير. راح نحكي الخطوات اللي احنا مشينا فيها حتى وصلنا لهذه الشهادة، ممكن نكون نستفيد منها جميعا. أتوقع احنا الأول مستشفى أخذنا هذه الشهادة. إن شاء الله المستشفيات الثانية ممكن تقدمها، والشغل مش صعبة إذا مشينا بالبروتوكول اللي هم طالبينه. So chest pain program performance and certification journey. احنا قدمنا الابلكيشن في جانيوري 2024. أول ما قدمنا الطلب احنا عملنا كوميتي، راح نحكي عن بعض الأمور في هذه الكوميتي. كان الهدف منها والالتيميت جول to reach and obtain the American Heart Association certification. ليش هذه الشهادة مهمة؟ طبعا الكل بيحاول انه ياخذ شهادات AHA Canadian European، لكن هذه الشهادة اكيد مهمة والكل ممكن يعتبرها من الشهادات المميزة. أولا to ensure the highest standards for patient with chest pain، نتأكد انه المريض بياخذ حقه according to the guidelines اللي هي حطيتها الامريكان هارت اسوشيشن. طبعا عشان احنا ناخذ هذه الشهاده عملنا الكوميتي، والكوميتي هذه كانت يعني فيها responsibilities. كان فيها بروجرام دايركتور اللي هو انا كنت موجود فيها، هو ليز ذا بروجرام ديفلوبمنت، وكان في عندنا بروجرام دايركت كوردينيتور السيد محمد كمال. كانت دوره مهم جدا، التنسيق بيننا وبين الاي اتش اي وبين الاذر ديبارتمنتس. طبعا اكيد احنا راح نحتاج الاداره في دعمها في هذا البروجرام. كان معنا كمان الميديكال دايركتور، وكان عندنا ريبريزنتيف من كل الديبارتمنتس، من الميديكال والنيرسري، من فارماسي، فيزيوثيرابي، education and equality department. كل هذول كانوا موجودين حتى نقدر نوصل وناخذ هذه الشهاده. المايلستون والتايم لاين لهذه الشهاده، احنا بدانا وقدمنا الابلكيشن في جانيوري 2024، وكان من بدايتها بدانا نعمل على هذه الشهاده. عملنا الكوميتي اللي حكينا عنها، ووزعنا المهام. يعني كل ممبر من هذه الكوميتي كان له ريسبونسبيلتي معينه. بعد ما عملنا هذه الكوميتي، اول شغله واجهتنا ان نشوف التشالنجز اللي ممكن احنا نواجهها اثناء التحضير لهذه الشهاده. كان عده تشالنجز، وبعدين عشان نحل هذا الموضوع عملنا سوليوشن اورينتد ميتينجز. يعني كانت اجتماعات يعني مطوله، اجتماعات متعدده في حتى نوصل لحلول للتشالنجز اللي هي واجهتنا. طبعا هم طلبوا منا انه نحضر ACS Clinical Guidelines Pathway. برضه هذه اخذت منا اشهر حتى قدرنا ناخذ الموافقه من الاي اتش اي على هذه الباثويز. وكانت طبعا ستاندرايزد كير بروسيس. يعني وصلنا لمرحله انه هم وجدوا انه هذه كافيه لنمشي في السيرتيفيكيشن. احنا طبعا عملنا خلال الفتره هاي دوكيومنتيشن كثيره، prepared policies, solution of problems، وكثير من الفورمات اللي ما كناش موجودين، ودوكيومنتيشن بعد ما بلشنا في هذا الباثوي حتى نحصل على هذه الشهاده. التريننج والاديوكيشن، يعني many comprehensive chest pain training for the hospital staff. كل ستاف كان له تريننج سيشنز، من الامرجنسي روم حتى من سكيورتي، من الكات لاب تيم، من الميديكال، من فارماسيست. كلها كان يعقدوا اجتماعات وتريننج حتى وصلنا للمرحله المقبوله. يعني رح نحكي عن بعض التشالنجز اللي واجهتنا عشان الوصول لهذه الشهاده. يعني التشالنج رقم واحد زي يمكن موجود في كل المملكه، اللي هي داتا مونيتورنج وكولكشن ايشوز. يعني كانت زي ما نحكي قبل ما نفوت على موضوع الشهاده some critical data اللي هي مهمه جدا مثل الاي سي جي والدور تو بالون تايم والتاو بي سي اي they were not organized, they were scattered or even not documented. بعد الاكشن اللي taken for this challenge يعني نظمنا automated system modified to allow specific diagnosis entities. كنا نشخص مريض chest pain لكن الان صرنا either you have to be clarify STEMI non-STEMI or نحكي cardiac pain. صار عندنا نيو كي بي اي فور اي سي جي within 10 minutes، يعني هاي من اهم الشغلات اللي احنا ركزنا عليها. وفي عندنا نيو داتا كولكشن ومونيتورنج تولز صار for created for PCI types, volume of performed PCI per each physician and patient gender taking. يعني هذا التشالنج ما كانش كثير صعب ان احنا نحله. يمكن التشالنج الثاني الاكبر اللي لحد الان هو موجود هو موضوع lack of EMS pre-notification اللي هو لما مرضى يجوا عن طريق الامبولانس. يعني معظم المستشفيات الآن بالذات المستشفيات الخاصة بتعاني موضوع إنه the AMS frequently transported patient without prior notification. يعني ما بتعرف إلا المريض صار عندك في الطوارئ، ما بتعرف إنه عنده المريض شو كان عنده كومبلين، بنعملوش ECG في الأمبولانس، بكونش في نوتيفيكيشن للمستشفيات إنه يحضروا حالهم الكات لاب تيم. فكان هذه من أكبر المشاكل اللي حتى الآن موجودة عندنا، يعني إحنا ما قدرناش نحلها. ويمكن ACS كمان كانوا مقدرين انه هذه الامور خارجه عن اراده المستشفيات بالذات المستشفيات الخاصه. فاحنا عملنا خطوات اللي راح نحكي عنها ومبادرات مع الدفاع المدني حتى انه نقدر ان نوصل لمرحله انه المريض قبل ما يوصل للمستشفى يكون معروف شو عنده، على الاقل في تشخيص ECG معمول مودة للمستشفى. اذا كان في MI STEMI انه المرضى المستشفى يحضر حاله ويحضر التيم تاع الكات لاب وينفورم الفيزيشن حتى نحقق الدور دوبلهم تايم اللي هو الاكسبتبل اللي هو less than 90 minutes. هذه مشكله كبيره ولحد الان هذه قائمه. طبعا هذه راح تؤدي ل delay في initial assessment and treatment and it will affect the net result of the patient عندهم myocardial infarction. هلا احنا في خلال الفتره الماضيه يعني كنا عملنا اكثر من لقاء مع مديريه الدفاع المدني، اجوا عندنا اكثر من اجتماع مع الاداره، وكان عندنا من ضمن احنا قدمنا مبادرات، من ضمن المبادرات هاي انه to have a unified notification system for AMS to alert the hospital of cardiac emergencies اللي حكينا عنهم، على الأقل يبلغوا المستشفى رايحين عليه إنه في معنا cardiac emergency، يعني be prepared for this. برضو إحنا قدمنا مبادرات training session for the civil defense paramedics، وإحنا كنا على استعداد إن نقدم لهم training في أشياء كثيرة من ضمنها recognition of acute coronary syndrome في 12 lead ECG acquisition and possible interpretation، على الأقل إنه يعملوا ECG 12 lead ECG pre-hospital care protocols. يعني كل هذول إحنا قدمناها أو إحنا كنا مستعدين نقدمها لمديرية الدفاع المدني للباراميدكس اللي بيكونوا في الأمبولانسز، لكن يعني كان في بعض العوائق اللي لحد الآن ما قدرناش نوصل لحل من خلالها. حتى احنا قدمنا لهم السيرفيس اللي ممكن قلنا لهم ممكن نودي انه عندكم تيلي ميديسن كابابيلتيز، نودي معهم اجهزه اللي ممكن من خلالها يبعثوا لنا الاي سي جي او اشياء احنا نطلبها من المرضى من الباراميدكس اللي بيكونوا موجودين في الامبولانسز. لحد الان هذه ما قدرناش نحلها، ان شاء الله انها تكون هذه اكيد راح تبدأ على مستوى البلد حتى نوصل لحل، وهي راح تكون فيها فائده كبيره للمرضى. الامبروفمنت اللي احنا حققناها من خلال حصولنا على الشهاده كان من اهمهم الاي سي جي. زي ما حكينا التايم تو اي سي جي واز نوت مونيتورد، لكن الان بعد ما طبقنا البروتوكول صار احنا عندنا 12 ليد اكوزيشن within 10 minutes في معظم الحالات او 100% من الحالات. الاي سي اس كلينيكال باثوي زي ما حكينا هم طلبوا منا يكون عندنا باثوي وجايد لاينز خاصه بالمستشفى، ناقشونا فيها عده مرات حتى حصلنا على الاكسبتنس والابروفل منهم وطبقناها الان في المستشفى. واحنا بعدين حطينا كود زي ما في عندنا كود بلو، صرنا في اسم عندنا ستيمي كود، يعني اذا في عندنا مريض عنده اكيوت ام اي في الطوارئ على طول الممرض المسؤول بيحكي مع المقسم بفعل الكود بنسميه احنا ستيمي كود. المقسم بيكون عنده ارقام تليفونات الكات لاب تيم وارقام الاطباء والطبيب المناوب، فهو بفعل كود اول ما يحكي يسمع انه في عندنا ستيمي كود بيحكي مع الجهات المطلوبه، وهذا يعني كان له فائده كبيره في تقليل الوقت المريض حتى يدخل على الكات لاب. والان هذا تقريبا هذا النموذج الموجود عندنا بالامرجنسي روم للمرضى اللي عندهم اكيوت كورونري سندروم. في عندنا التايم، في عندنا الاكشن، وفي عندنا النيرس نيم وسيجنتشر. بيبدا في الترياج اول ما يوصل للمريض، بعدين بيحط كله بيكون فيه توقيت انيشال تشست بين بروتوكول، بيبدا بيحكي مع طبيب الطوارئ. 12 ليد اي سي جي لازم يكون خلال 10 دقائق، واذا كان نورمال ممكن يعيده خلال 15 ل 30 دقيقه اذا كان نورمال وستيل هاي سسبيشس انه هذا اكيوت كورونري سندروم. وبعدين بيبدا البروتوكول تاع التشست بين مانجمنت. يعني هذا مثال على الاي سي جي within 10 minutes. يعني احنا بدأنا نطبق البروتوكول قبل شهر 8. ما كانش عندنا 100% الاي سي جي within 10 minutes، لكن بعد شهر 8 9 و10 100% of patients they have their ECG within 10 minutes. وهذا انعكس طبعا على نتيجه المريض اللي هي دور تو بالون تايم، اللي هي بنعرف كلها اقل من 90 دقيقه. يعني قبل شهر 5 كان عندنا ما بين 75% الى 90% انه دور تو بالون تايم within 90 minutes، لكن طلع في شهر 5 وبعد ذلك كان 100%. كل المرضى كانوا يروحوا على الكات لاب ودور تو بالون تايم less than 90 minutes. هذه حاله يعني من الحالات اللي احنا مشينا فيها بعد مقدمه البروتوكول. مريض عمره 49 سنه، اجى في تشست بين، المريض اجى اذا بنحكي عن توقيتات يعني اجى على 11:44 دقيقه. بعدين صار البروتوكول نعمل الاي سي جي within 4 minutes، بين عنده ST elevation في الانفيرو ليدز 4 minutes within 4 minutes. والكات لاب تيم was activated by the nursery supervisor بعد نحكي 8 دقائق، واخذ ميديكيشن اسبرين وانفلكشنيتد هيبرين. بعدين راح الكات لاب تقريبا وصل على 12:14 دقيقه. التيم وصلوا 12:14. المريض كان بعد 4 دقائق في الكات لاب. وبرايمر بي سي اي واز بيرفورمد لانه كان عنده انفيريوم اي 2 stents to the right coronary. الدور تو بالون تايم كان 46 minutes 2 stents to the right coronary. بعد البروسيجر المريض راح على السي سي يو 1 و10 دقائق كان بالسي سي يو. نعمل له اي سي جي كان نورمال تقريبا. السيلفيشن راحت. نعمل له ايكو ايجكشن فراكشن 55 مايلد انفيرور هايبوكاينيزيا. البيشنت اديوكيشن مريض تحسنت اموره ثاني يوم. صار وي توبك covered with the patient with the family risk factors and signs of symptoms of ACS medication regimen and adherence والياتري modification. كل هذا انحكى مع المريض. وهذه الشهاده اللي احنا اخذناها من AHA Comprehensive Chest Pain Center Certification awarded to استقلال Hospital. كانت November 12 2024 it will be expired on November 11 2027. Thank you.
Thank you, Dr. Nael. We will move to another topic, but now about neurology and acute stroke with Dr. Murad Rashid and AHA experience in specialty hospital with acute stroke.
Assalamu alaikum. First of all, I would like to thank the organization committee for their invitation to talk about stroke and experience from stroke cardiology meetings. Really, in my talk, I will concentrate on the how to improve the care of a stroke. I will not go for all of these sequences to be certified for stroke units. First of all, there is some facts about stroke, where the stroke is the second leading cause of death and the third leading cause of disability worldwide, and each year nearly about 8,000 people experience a new or recurrent strokes, and every 40 seconds we have patients with a new stroke, and every 4 minutes somebody die from stroke. And stroke is a major cause of morbidity and permanent disability. We have two major types of stroke, either it's ischemic or hemorrhagic in nature, and the stroke management vary depending on the type of stroke. Regarding the incidence, most of stroke are ischemic in nature. They account for 80-70% of ischemic stroke, and hemorrhagic stroke account for 30%. Whereas atherosclerotic vascular disease leading to ischemic stroke for 20% in patients, and 25% related to small vessel disease, lacunar strokes, cardioembolic strokes about 20%, and 30% remained undetermined or cryptogenic strokes. And other causes count for about 5%. What's happening in the stroke, if you see the brain in the left, you can see the red area. This is red area, this is the ischemic score, where we get a dead neuron or dead tissue. And around the ischemic score, there is a hypoperfused, hypofunctioning area, what we call penumbra, and this is an unsalvageable area. If we maintain rapid reperfusion, and you are looking for the brain in the right side, we can reduce the ischemic injury to the brain by maintaining maintaining hypoperfusion and preserve this penumbra, okay? And we get, by default, a better outcome for our patients. Really up to date, thrombolysis is underused, and only 50 to 20% of acute ischemic stroke patients receive IV thrombolysis, and 2/3 of cases that receive TBA, door-to-needle time is more than 60 minutes, and the recommendation time is less than 60 minutes. And the problem is because of the delay of arrival. Most of the patients, they arrive to the hospital outside the time window, and because of non-availability of TBA in the hospitals, or in hospital delay sometime happens, or prolonged time to imaging by CT or MRI after arrival to hospital. So if we improve pre and in hospital procedure, we can increase the number of patients who receive thrombolysis. This is the key barriers and hurdles for acute stroke statement. Our goal achievement, the triage room, every patient with suspected stroke should be seen within 10 minutes. And the barrier for not achieving this goal is the lack of stroke awareness among the public and GPs, lack of stroke awareness as a priority, limited resources in the staff and the facilities in the hospital, committing demands in emergency department, and lack of staff coordination, and lack of training in hospitals. So to solve this problem, if we have an availability to stroke care protocol, we can solve all of these barriers and improve care for a stroke. Every patient should be assessed for thrombolysis, and every patient who is eligible for TBA, he should receive a TBA. What's the effective strategy we have to take to improve the outcome in acute stroke? First of all, public awareness campaign to recognize the stroke symptom and put out the call for help. And we, in specialty hospital, we collaborate with the emergency medical services with multiple workshops for increased awareness of stroke symptoms, specialty training, emergency response team. We perform many workshops in our hospital to train the staff and train emergency medical services provider. The stroke network, giving a priority and direct transfer to the specialized stroke center or a stroke unit. We have to act fast to initiate the thrombolysis, and management should be multidisciplinary by multidisciplinary team. The earlier treatment of acute stroke with thrombolysis, the better outcome. Any stroke care run with 3 stages, basically. Pre-hospital stage and hospital stage and post-discharge, and the whole 3rd stage was extended for up to 1 year from discharge. So if we have an effective emergency medical services system, we can minimize the delay in pre-hospital dispatch and assessment and transport, and we can increase the number of acute stroke patients reaching the hospital and receiving thrombolysis therapy within the approved time window. The importance of pre-hospital management of suspected acute stroke. The optimization pre-hospital care improves stroke patient outcome, and emergency medical services play a critical role in the initiation, assessment, and management of suspected acute stroke patient. Giving a priority by emergency medical services and appropriate transfer of the patient for acute stroke center facilitate area diagnosis and the treatment. And acute intervention such thrombolysis at time is very sensitive. The earlier thrombolysis is given, the better the outcome. And the pre-hospital evaluation should be extended beyond the stroke recognition to stroke severity. The fact that we have to establish by the emergency response team once we get call our patient with suspected stroke, first of all, time of onset, it's mandatory to maintain. Doing unsimplified NIHCC, NIHSS, this is on a scale for severity of a stroke. And usually we do modified scale, motor deficit or consciousness or language, or we can use the FAST test. الفاست اللي هي reflect face drop and arm weakness and speech difficulty. Collecting vital signs, the ECG if possible. We have to exclude the hypoglycemia. For that, the glycemic state is very important to establish taking history if a patient is on blood thinner or antiplatelet medication. If this is an first stroke or not. An initial evaluation as for any emergency patient started from ABC. Blood test sugar is mandatory for each patient who became with acute stroke to exclude the hypoglycemia, which is main mimic for stroke. Regarding the blood pressure, any patient with suspected stroke who presented with blood pressure less than 120, usually we advise to initiate IV normal saline infusion and aim to raise his blood pressure to increase the reperfusion. And if his blood pressure is systolic more than 220 and diastolic one is less than 120, no action should be taken. For patients with systolic blood pressure more than 220 and diastolic blood pressure more than 120, we can start IV medication, including beta blockers, calcium channel, or ACE. I think we only have labetalol here in Jordan. Collection of history, concentrated on the time of symptoms, comorbidities, the development of system, and current medication, especially anticoagulation is mandatory, with level of function and dependent burial onset of symptoms should be maintained in history. These are mimics that can mimic stroke and ER, and everybody should be aware of it. One of the mimics are encephalopathy, either it's metabolic or toxic encephalopathy, hypoglycemic state or hyperglycemic state, migraine, one of the mimics of a stroke, tumors, post-ictal state, and thoughts paralysis, post-seizures, hyponatremia, factitious stroke, psychological disorders, syncope, fitness, dizziness, and a problem with balance. We all know that the neurological examination prolonged, and the examination, neurological examination that be needed in ER. For the screening, we use a FAST test usually, and for the severity, we are use an NIHS scale or modified NIHS scale. What is the importance of emergency medical notification? The pre-hospital notification and transport of suspected acute stroke patient while AMS reduce the in-hospital delay in stroke evaluation, including time of stroke team arrival and time of CT scan completion and interpretation. Even if there is an direct communication with the neurologist, it will be better. It's increased the number of patients undergoing timely imaging and image interpretation by physician compared with the patient arriving by the private transport, and it increases the likelihood of administration of TBE. Mobile stroke unit. Hope we will have it in Jordan. It's available now in Gulf. It is ambulance equipped with CT, point-of-care laboratory, and telemedicine equipment to contact with hospital experts. What's the immediate aim in hospital acute stroke care? Immediate aim are access to specialist stroke care, rapid assessment, and direct access to imaging and early thrombolysis for eligible patients. In hospital care, we have restrict time for each steps. For door to medical department, we have 10 minutes or less to perform an assessment, evaluate the patient, collect the history, and send the lab tests. And door to stroke team notification should be with less than 50 minutes, and door to CT scan should be within 25 minutes. Door to needle should be less than 60 minutes. This is our target. What the intervention can reduce or can maintain a door to needle for less than 60 minutes. As I said, the emergency medical pre-notifications improve this time, laboratory test. The only test we need for stroke patient before proceed for TBA is the only blood sugar. And INR only used if anticoagulation suspected. The transport to CT direct from emergency medical service to CT upon hospital arrival. The CT scan availability 24/7 of a technician, and the interpretation should be first taken by a neurologist, not waiting for a radiology report. A TBA delivery you can administer from a CT table. Yeah, it's kidding. The activation, what's the importance
1 minute,
of
Dr.
activation?
Murad,
Yeah.
1 minute.
Okay. What's the importance of activation of cold stroke? Cold stroke aim to achieve right stroke assessment and treatment and retrospective data from 98 patients with cold stroke and from 108 non-cold stroke patients showed that 18 minutes movement in door to the needle time for cold stroke patients. This line, we have usually say time is muscle, and we as neurologists say time is brain. And lost time means lost brain. How can we recommendation to increase the awareness of stroke? As I said, sustain the program to increase the public awareness, immediate activation of emergency service, and educational program for healthcare providers. Brain imaging, I have to some slides for brain imaging. The brain imaging to determine the velocity of thrombolysis. For acute brain imaging, non-contrasted CT remain the image mode of choice due to ability to detect intracranial hemorrhage and due to cost effectiveness. And it should be available 24 hours in the hospitals, and the achievable time from door to imaging should be less than 20 minutes. Non-contrasted CT is the necessary, non-contrasted CT will provide the necessary information that we need to decide a decision for thrombolysis. And if MRI is used as alternative, and we have an indication to use CT, it should be included in the evaluated image and T2 gradient echo to detect repeat. Multimodal CT and MRI, including the perfusion imaging, should not need thrombolysis. If we are planning for endovascular thrombectomy in cases of severe stroke, we have to obtain intravascular imaging, including intra and extracranial vessels. For patients who became for more than 6 hours, advanced imaging by infusion perfusion MRI to identify patients eligible for mechanical thrombectomy. Okay, selected patient with 2 slides on the patient. Inserted patient with large vessel occlusion and arterial circulation who became 24 hours after onset of acute ischemic stroke. CT, ORR, diffusion, method MRI study are recommended to assist and determine eligibility for mechanical thrombectomy. And in some patients, when planning mechanical thrombectomy, collateral flow study will be necessary to for the decision process, and in patient with wake-up stroke in whom time of stroke onset is unclear, usually monitor MRI perfusion for this match. The benefit of thrombolysis therapy in intravenous TBE is time dependent. Therefore, treatment should be initiated very quick. This is a reminder of the dose of TBE, 0.9 milligram per kg per body weight. Maximum dose that we can give 90 milligram, 10% of the dose given as bolus dose, and the remaining dose as infusion over 60 minutes. And the intravenous TBE also can be administered in selected patient under 18 of year and after 80 years of age. So the age is not contraindicated after 80.
I think we need to move to the next session, please.
Okay, thank you.
Next speaker, Dr. Majid Zubaidi, bridging the gap, implementing AHA guideline in the Middle East.
السلام عليكم. بداية أشكر الزملاء في جمعية القلب الأردنية وكذلك جمعية القلب الأمريكية على الدعوة. So I was assigned this task, and basically it's a long journey. It's many years of work, so it's difficult to summarize it within 10-15 minutes, but I'll do my best, inshallah, to give you a snapshot of some of these journeys, highlights from this journey. So all of us, we know that and the focus here is mainly on STEMI, out of the chest pain continuum. So the incidence of STEMI, as you can see here, represented with the blue, is declining, and this is most of the data comes from the West, but I'm sure we're somewhere in the either from 50 per 100,000, 50 STEMIs per 100,000 to somewhere around 150 STEMIs per 100,000. So a population of 10 million like UAE, and I'm sure Jordan is somewhere around that population. So you're having around, maybe if you say 100 per 100,000, maybe there's 10,000 STEMIs and within the country. So STEMI is a high risk, as you all know, and mortality rate is extremely high if the patients are not recognized early, diagnosed early, and got the best care. We have a lot of options that we can give these patients, and if they're not diagnosed, not triaged proper, unfortunately, they can, they can get a terrible outcomes. Now, one of the key treatments for STEMI is reperfusion, and we know TPA versus primary PCI. Those are the two ways to open the artery, and we have enough evidence. There's a lot of evidence that primary PCI is better than thrombolytic, but it has to be available in timely fashion. So it's not, if it's delivered late, then probably thrombolytic would be better. So it has to be timely, and it has to be done by an experienced operators. So we have to fulfill that, and we asked ourselves in UAE or Emirat, can we deliver this strategy? So if we have as a system, if we pick primary PCI as a strategy, can we deliver it according to what the guidelines have stated, which is timely and done by an experienced team? So this is the dilemma, and the availability, we all know thrombolytic is available. You can put it in every emergency department or every clinic even. So it is available. Primary PCI is not available everywhere. It has to be a cath lab center and operators and so on. Eligibility of patients, of course, we also who practice or who does intervention, we know almost all patients are eligible for primary PCI. However, thrombolytic, not everyone. Only 60% of the, and we hear from the stroke also the same thing. So not everyone is eligible for it. Reperfusion success with primary PCI is better. And of course, reocclusion is higher with the thrombolytic, and stroke rate is higher. So it is very clear that the best reperfusion strategy will be primary PCI. Now, so the procedure is one thing, but the process and getting the patient to the cath lab is the challenge. So doing the process, most of the guidelines started to talk, or most of the societies came up with statements around system of care. So you need to fix your system. All the stakeholders need to sit and talk. Either it's the EMS, the emergency, the cardiologist, and so on, and the regulators and the payers. So everyone has to be around the table, to ensure that the system is fixed, all the system factors. So our experience, we went and looked at the map, and as you can see here, and this is something that I have to disclose. I had some responsibilities within the Abu Dhabi area. So we worked within Abu Dhabi for 10 years on STEMI care, and recently, over the last 5 years, I've been doing more work within the Northern Emirates. So in Abu Dhabi area, as you can see in the first map, there's a lot of centers, a lot of clinics, and a lot of hospitals. So the patient with chest pain can present anywhere. The question is, if the patient presents to a small a small center with the chest pain, and he gets an ECG, and that ECG is a STEMI, he has to get to the cath lab or to a primary PCI center within a timely fashion. Otherwise, primary PCI as a system may not be the best option. So we established task forces and different committees at the level of hospitals and at the level of a system. And we looked at barriers, and we started addressing the barriers. And in summary, and I pulled this out of one of the system statements that I showed you early. They classified barriers as modifiable and non-modifiable factors. And to be honest, the only non-modifiable factors would be with weather. And in our region, we don't see it. So there's no fog or ضباب or عواصف. That doesn't exist. The only thing is travel time. I mean, travel time can be an issue, especially for a remote area. The rest is modifiable, but it needs a lot of effort and needs people to talk to it. So if you look at Abu Dhabi Emirate only, because also this is one of the things for Emirat, is we have different regulators. So Emirat Abu Dhabi, we have Department of Health. In Dubai, there's Department of Health also of Dubai, and the Ministry of Health is covering the Northern Emirates. So we have different regulators, and so that's one of the challenges, but also it's an opportunity because also there's a competition. Everyone wants to deliver a better care. So if you look at this map, Emirat Abu Dhabi, the population here is about 3 million. But you have to recognize that 63% of the population, they live in a small area. So if you have 2-3 hospitals that provide the primary PCI, all that population has an access. So, and then the same thing within the Eastern region, the same thing, 23%. So 90% of the population are living close to a primary PCI site. So basically 90% of the population can access cath labs. The remote areas, which is difficult travel time, which is a barrier, represents only 10% of the population of this emirate, and which is about 3 million population. So we say, let's focus on the areas that has the condensed area, and then we can talk about the rest. Now, the other factors or the other challenges that we faced is, all the different providers, as I mentioned earlier, a lot of hospitals, a lot of centers, but also different payers, a lot of insurance companies. We have more than 40 insurance companies that I could list, and I think there is more. And as I showed you, a lot of centers, more than 1,300 centers within Abu Dhabi. So the patient doesn't know if he has a STEMI or he has an MI. He shows up with chest pain, and then the system has to figure him and triage him. to get to the right place. So we started the work long time back, and we started our focus mainly on the primary, on the cath lab centers, or the primary PCI centers back then. And then we moved to, once we ensured that the centers are delivering good care to those who walks into their door, then we moved to the community hospital and started to establish some connections with them. And then we went to some of the remote areas, and we adopted the drip and ship protocol. And later on, I think 3-4 years, started working with the EMS, or civil defense, or الدفاع المدني, that owns or operates الإسعاف أبو ظبي. So it took us a long time to get to the EMS. And of course, we talked about pre-activation, or one of my colleagues talked. We started with them pre-activation, and we did the pre-activation in a pilot phases, and then we expanded to cover the whole emirate. So it was gradual. One of the key things I think I want to share with you is data. Data is very important. You cannot address anything without having data, and we have a dashboard that all the hospitals participate and log their data within it. As you can see here, I'll highlight something here. It says 70% of those who comes to to the system, they don't call EMS, they don't call الإسعاف, they walk into the door. So still, those who comes through through the EMS or through the ambulance are not a majority. For cases utilizing pre-hospital EMS, 80% of them were transported to PCI hospital directly. So the culture now in the EMS is to bypass small hospitals or hospitals that does not have a cath lab. And that goes back to the regulators. The regulators are into licensing facilities as a primary PCI. So not everyone can do a primary PCI unless he has the license where he fulfills the criteria and the standard criteria. And we adopted the AHA standard criteria for a PCI, for a primary PCI site. So this is the in, door out time for the cases. As you can see, this is still we're having some challenges there because of the community hospitals. This is the device or the door to device time. And for those transferred patients, it's monitored closely, and if, we try to identify the facilities that are deviating. This is the system door to balloon time, or door in, door out time. We identify those who are, not meeting the standard, and we address them, and of course, the regulator goes after them. Multiple achievements, of course, one of them is getting an accreditation, and we use the accreditation to ensure that all the providers are meeting the standards or the minimum standards. So we have the accreditor who monitors those standards, those hospitals. I'll move to so that's the Abu Dhabi model.
Left, please. 1 minute left.
Sure. So the other model, I guess, is the Northern Emirate model, which is something closer. So we had we identified the gap, and we started back in 2020. We identified all the challenges there. We have a project plan, and this is just an example from one of the hospitals where a door-to-balloon time was very long. You see the lengthy, complicated process. You have to map those processes. If you have the map and you map it, then that process, that complex process, after a few months, we eliminated all those steps. We look at the system as, we identify the central hospital, the hospital that the patients are going to go to, and then the community hospital, the driving time. And gradually, as you can see here, we got to cover all the hospitals. This is the number of patients that we treat every year. Last year in this system in the Northern Emirates, this is all STEMI patients that are treated with primary PCI. I'm just going to show you at the end here so this is the data of the door-to-balloon time within the Northern Emirates. Door-to-balloon time is maintained, all below 120 minutes. Most of these patients are transferred from community hospitals around the whole area. So these hospitals also cover about 3 million, almost 3 million population. and all the hospitals transferring to 2 centers at this time. Finally, I'm just going to show you one of the hospitals' data from Get With The Guidelines. This is 2024. They treated 480 STEMI patients in that hospital, and they report their data together with the guidelines. So this is the mode of arrival. As I said, 75% of the patients, they arrive as a walk-in. This is the age, gender, and risk factors for those patients. It gives you the medication history of those patients, so you know the quality of and the metrics there. You know, previous medical history, the treatment the patient received. You know, it's a PCI or it's not. Of course, these clinical characteristics. The metrics, as you can see, are monitored closely, and if there's any deviation, of course, we look at it. This is the metrics comparing with the receiving centers globally, so it's benchmarked to international centers. And this is the mortality adjusted, also compared to the international benchmark. Complication rates also, so we can compare hospitals and centers accordingly. And you know, a few slides on cardiogenic shock. So we have a big initiative on cardiogenic shock and mechanical support, and I don't think time is enough to share with you that. So in summary, I think you know, as a system, you need to define your reperfusion strategy. So it's not everyone gets a thrombolysis or primary PCI. If you are going with the primary PCI, it has to be, you know, the system has to support it. The map of the system has to be clear, and every patient with chest pain has to, every provider, when he faces a chest pain, he has to know where this patient is going to go to. So it's not the time to triage patients with financials and so on. The patient needs to go to the cath lab and without, you know, all those obstacles. Of course, the referral process has to be streamlined, and as I mentioned, defining quality metrics is key, and tracking quality metrics is also very key. Communication across the system and feedback is very, very important. Otherwise, gaps continue and people keep blaming each other. That's a lot to share.
Thank you, Dr. Abdelmajid. Online is ready. Can we move to Dr. Hani Junaid, online lecture?
No. I trust it's good afternoon in Amman. Here in Houston, it's good morning. It's تقريبا 7 إلا تلت. So صباح الخير من Houston ومساء الخير من عمان. Thank you for the kind invitation. You can see my slides, I trust, right? I'm Hani Junaid. I'm a professor and chair in the Department of Cardiovascular Medicine, the director of Celia Heart and Vascular Institute, and the vice president of cardiovascular operations at the University of Texas Medical Branch. It's an honor and pleasure to be here, invited virtually to speak at the Jordan Cardiac Society. So thank you for that kind invitation, and thank you for the American Heart Association for coordinating this landmark symposium. Today, I will be speaking about ACS complications in the emergency room. Before I start, I want to tell you a little bit about UTMB, or the University of Texas Medical Branch. We are a large healthcare system. Our clinical operations span 3 counties in the greater Houston area and in Galveston. And we have 4 hospitals and 9 clinics. And many of my faculty members are actually from the Middle East, including from Jordan. So hopefully next time we'll bring some of the American Jordanian speakers as well with me. So pertinent to this talk, I have no disclosures and no financial relationships to disclose. And I will not be discussing any unlabeled or unapproved use of drugs. I will start by giving brief definitions and general considerations pertinent to acute coronary syndrome, with insights from the recent 2025 ACC/AHA guideline. And then I will delve into some of the ACS complications that you see in the emergency room. I will talk about some of the hemodynamic disturbances, mostly heart failure and cardiogenic shock and mechanical complications. I will touch on pericardial complications, on arrhythmia and cardiac arrest. I realize I have 15 minutes or so to cover this wide topic, so I'll be very selective in my discussion of some of these items. So this is the 2025 ACCHA guideline for the management of patients with acute coronary syndrome. This is the most updated guidelines for this condition by our cardiac societies. I had the privilege to serve as the chair of the peer review committee for this guideline, so I'm very intimately familiar with this guideline. Few definitions, just to start with. As you know, ACS is usually either non-ST elevation ACS or ST elevation MI. Non-ST elevation ACS can be divided into non-ST elevation MI or unstable angina, depending whether it's positive biomarker versus non-positive biomarker. And the EKG changes are usually ST segment depression, T-wave inversion, or non-specific ST T-wave changes. And this is usually a partially occlusive thrombus in the coronary artery, as opposed to an ST elevation MI presentation that usually have the pathophysiology of a completely occlusive thrombus with an acute current of injury and over time cardiac biomarker release. Again, when we're talking about ACS for the sake of this topic, as well as in the guideline, we're talking mostly about type 1 MI, according to the fourth universal definition of MI. So this is one that's caused by acute coronary arterial thrombosis, usually precipitated by plaque disruption, rupture or erosion, and often associated with partial or complete vessel thrombosis. So we'll not be talking about type 2 or other types of myocardial infarction. And just in the emergency room, you know, the hallmark for diagnosis after a good focused history and physical exam is the electrocardiogram. And with non-ST elevation ACS, as you may know, you will see new or presumed new or usually dynamic horizontal or downsloping ST segment depression in 2 or more contiguous leads, or T-wave inversion in 2 or more contiguous leads. With ST elevation MI, you need a new or presumably new ST elevation of more than 1 millimeter in 2 contiguous leads, measured at the G point in all leads. But if it's V2, V3, you'll need more than 2 millimeter in men above 40 years of age, and even more than 2.5 millimeter in men who are younger. And for women, you will need 1.5 millimeter of ST elevation to characteristically diagnose ST elevation MI in these leads. Now, a word of caution, the absence of electrocardiographic evidence of ischemia obviously does not exclude non-ST elevation ACS. And for ST elevation MI, whenever you have a suspicion of true posterior MI, as seen by isolated ST segment depression in leads V1 to V3, you would want to get posterior leads to rule out posterior MI, especially when you have a suspected left circumflex occlusion, which is usually electrically silent on the traditional 12-lead EKG. Let me start with the complications of ACS that you may encounter in the emergency room. So the most dreadful one is really hemodynamic. They're all bad, but cardiogenic shock is one of the most dreadful complication. And it happens with both ST elevation MI and non-ST elevation MI. Actually, with non-ST elevation MI, it portends higher in hospital mortality, but it's more commonly encountered when ST elevation MI, and 80% of the time is related to an extensive LV myocardial damage. In 20%, it could be either mechanical complication or predominant RVMI. Incidence, 5 to 7%, and you all know it's usually persistent hypotension, reduction in cardiac index, and congestion defined with a PCWP above 18 millimeter. And low output state will lead to vital organ hypoperfusion, as evidenced by cloud sensory, cool extremities, oliguria or anuria, and systemic acidemia. So you've got myocardial dysfunction, both systolic and diastolic, with cardiogenic shock, with reduction in cardiac output, stroke output, and hypoperfusion, but also you have pulmonary congestion from elevated LVDP. And the goal here is to maintain systemic pressure as well as decongest the heart. There's also systemic inflammatory response syndrome and the release of inflammatory cytokines. And after some time, cardiogenic shock go from a predominantly cardiac disease to a multi-organ dysfunction. And this is when it really is associated with a tremendous mortality. Early revascularization remained the mainstay treatment for cardiogenic shock complicating acute myocardial infarction. And this is the early shock trial from 1999, showing 13% absolute risk reduction in mortality at 6 months, actually. This is when the endpoint was met at 6 months, as opposed to medical therapy. The primary endpoint in this trial actually at 30 days was not met, but it's the 6 months that showed unequivocal benefit. And the benefit is seen across all ages. So we do not discriminate against the elderly. Earlier, this subgroup analysis in a small cohort showing no benefit above 75 years of age, but so many studies afterwards showed that every patient subset, including the elderly and particularly the elderly, will benefit from revascularization. This is one of our early meta-analyses showing survival benefit in patients in the older age groups. This is a patient with presented with cardiogenic shock. That's one of my patients. You could see here his aortic pressure, not only a blunted systolic blood pressure, but a very narrow pulse pressure, which tells you that his cardiac performance is extremely low. And we have multiple mechanical circulatory support devices to support those patients, including a balloon pump, Impella, tandem heart, ECMO, and others. Balloon pump does not work anymore. The SHOCK 2 trials showed that in acute MI complicating cardiogenic shock, there's no benefit at 30 days and also at 1 year from the utilization of a balloon pump. And the recent guideline this year, for the first time, have a class 2A recommendation for the use of Impella devices, or what we call microaxial intravascular flow pump, to support cardiogenic shock patients complicating ST elevation MI. So this is in the aftermath of the dangerous shock trial that showed a mortality benefit in the cath lab. So in patients with mechanical complications of ACS, short-term circulatory support devices are also reasonable for hemodynamic stabilization as a bridge to surgery, and there's no benefit from balloon pump or ECMO in these patients because the data showed really no benefit. Let's move from cardiogenic shock to LV failure or acute congestive heart failure. And again, the goal of treatment is really to decongest the heart and maintain systemic pressure. In these patients, usually their blood pressure may tolerate unloading medication, and that's why inotropic agents should not be the initial therapy of choice in patients with heart failure and acute MI. Instead, acute heart failure should be managed most effectively by reduction in both preload and afterload, and also by other means, including avoiding arrhythmia, and which may contribute to hemodynamic compromise. So besides treating hypoxemia with oxygen when the patient is hypoxemic, you'd want to decongest the patient with a diuretic, IV bumetanide, furosemide, or torsemide, and importantly, unload the heart to improve the cardiac performance. So you want to reduce the LV afterload, but avoid excessive hypotension, and importantly, avoid excessive reduction in LV filling pressures, particularly in patients with RV dysfunction. So IV nitroglycerin followed by oral agents will be ideal. Nitroprusside to be used very cautiously in patients who have ischemic symptoms and acute congestive heart failure. But if patient had very elevated afterload or systolic blood pressure, you would want to use IV nitroprusside, which is a fast-acting medication, very cautiously in patients who do not have significant kidney dysfunction because of the potential of cyanide toxicity and so forth. But when LV failure is severe and unresponsive to diuresis, then this is the time to use inotropes, whether beta-adrenergic agonists or phosphodiesterase 3 inhibitor like milrinone. So dobutamine or milrinone are what we use. and the dopamine has only an effect on the renal and splanchnic vessels, so it should be used at a very low dose. And with hypotension, you can add norepinephrine to dobutamine or to milrinone. Now let's talk about the other complication, another dreadful complication of ACS. This is the mechanical complications. And this is from the 2025 ACS guideline. These are the 4 types of mechanical complications. You have open muscle rupture, ventricular septal rupture, contained rupture, and free wall rupture. Free wall rupture really is lethal, and it's for the most part very difficult to salvage. Contained rupture usually can be observed and is not as acute for an emergency as muscle rupture or VSD, ventricular septal rupture. This is one of our analysis from NIS administrative databases showing that the mechanical complications in ST elevation MI can occur in 0.27% of hospitalization, and it's much lower in non-ST elevation MI in the range of 0.006% complication. Mortality is very, very elevated, more than 40%, and you could see here that the mortality has not changed at all over time, remain in the 40-50% range all throughout. Let me just touch base on one of these mechanical complication entities, which is ventricular septal rupture. So it usually occurs 3 to 5 days after acute MI, ranging anywhere between 24 hours to 2 weeks. Just for the sake of time, about the clinical manifestations, you have a quick hemodynamic compromise with hypotension, biventricular failure, predominantly RV failure, and on auscultation, you will hear a very harsh, loud holosystolic murmur, and in 50% of the time, there's a palpable thrill and the RV lift from the acute shunts, as well as a hyperdynamic precordium on physical exam. Obviously, echocardiogram in the ER is the mainstay diagnostic modality with Doppler imaging, and these patients should be stabilized with mechanical circulatory support devices, taken to the cath lab, and then subsequently to surgical repair. This is one of my patients many years ago. This is the left atrium. We did a tandem heart in this patient. We crossed with a tandem heart all the way from the venous, from the right atrium to the left atrium, and to put a tandem heart. And this is the opening pressure in his left atrium with a very large V wave, all the way up to 35 millimeters. So patients, according to the 2025 ACS guidelines, patients with a mechanical complication of ACS should be managed in a facility with cardiac surgical expertise. So if they come to the ER, you would want to stabilize them with a mechanical support device and then transfer them to the nearby hospital with a strong cardiac surgical capability. Let me switch from hemodynamic disturbances to pericardial complications of acute MI. And these are really more common. So peri-infarction pericarditis, pericardial effusion, and post-cardiac injury or Dressler syndrome. So these complications are related usually to the infarct size and have been declining in the incidence in the revascularization era, except for pericarditis. It remains common, but much less common compared to before because of lesser frequency of full-fledged transmural infarcts in the era of fast, expeditious, and complete revascularization. So peri-infarction pericarditis usually occurs soon after ST elevation MI is transient, and it used to occur much more often in people who were not reperfused. And in those patients, usually hear a friction rub in the first 2 to 3 days after an acute MI, which denotes a very large infarct size and lower EF, and usually an anterior location. And the diagnosis is as follows. This is again from the 2025 ACS guidelines. You would want a pleuritic chest pain that's characteristic, plus one or more of the following criteria: a friction pericardial rub on auscultation, EKG evidence of pericarditis, such as classic PR segment depression or diffuse concave ST elevation in the setting of an ACS, obviously, and new or growing pericardial effusion on echocardiography. So we'll need one of these three. Now, if you've got peri-infarction pericarditis complicating ACS, as in somebody who's really presenting late to the emergency room, you want to avoid anticoagulation if a pericardial effusion develops or increases. But if the patient had no effusion, there's no need to alter anticoagulation therapy in most patients. And again, if friction rub does not necessarily increase cardiac tamponade risk, but the presence of an effusion, you want to be very careful with anticoagulation. And early on, or in the setting of ACS, or early on after ACS, you would want to avoid non-steroidal anti-inflammatory drugs because the possibility of scar thinning and infarct expansion, and even because of conceptual risk of increased incidence of aneurysm or free wall rupture, aspirin or colchicine remain the preferred therapeutic agents. And this is the doses of aspirin and colchicine as per the 2025 AHA ACS guidelines. You would want to use high dose aspirin or colchicine, and colchicine you can use up to 3 months for those who come with persistent or late pericarditis symptoms.
We are left with 2 minutes, please. 2 minutes more. We
Yes,
are short of time.
Certainly. Pericardial effusion used to be common in the early course of an acute MI. It's usually most often minimal or mild, and when it happens, it's associated with higher mortality or morbidity. Dressler syndrome is an autoimmune disorder that can happen late complication for MI. You may see these patients coming several weeks after the MI presentation to the ER, and usually treatment is NSAID drugs. And let me touch now on the third set of complications of ACS. Arrhythmia is one of the very common complications of ACS. And I want to just touch base on really the cardiac arrest given the sake of time. I want to remind the audience about the recent 2023 American Heart Association focused update on adult advanced cardiovascular life support and some other recommendations in this recent guideline. So whenever you have somebody with cardiac arrest complicating ACS, you would want to obviously start with epinephrine at 1 milligram dose every 3 to 5 minutes for cardiac arrest, and you want to avoid a high dose epinephrine because of lack of benefit. And very important to add amiodarone or lidocaine in the case of suspected ventricular fibrillation or pulsus ventricular tachycardia. And also, it's important to remember that the routine administration of calcium, sodium bicarb, or magnesium is not recommended in patients with cardiac arrest presented to the ER following ACS. ECMO has no role, is reasonable to utilize in select patients presenting with cardiac arrest. However, in those without cardiac arrest but acute MI, there's no benefit of ECMO. But this is only a class 2A reasonable to use in the case of cardiac arrest. For the sake of time, I'm going to be stopping there, and I'm happy to take any questions from the audience. Thank you very much for
Thank you very
inviting
much.
me.
Any question? Let's have a question for Professor. Anybody has a question? Yes, sir. Go ahead. نبدأ سماعة. We have one question.
Yes, sir.
Okay. Good morning, Dr. Hani, Professor Hani.
Good morning. Is it Sabah?
I want to ask, when do we stop the anticoagulants in peri-infarct pericarditis? You mentioned after having effusions.
Yeah. So the presence of rub by itself you don't have to stop anticoagulation. So somebody is coming with ACS and suspected pericarditis. So you see, you hear a triphasic rub there, and he's got a typical pleuropericarditic discomfort complicating a recent MI. It's a very good idea to get a bedside or point of care ultrasound and see if they've got an pericardial effusion or not. If it's only rub, it's okay to continue anticoagulation if you suspect that this patient need anticoagulation because it's a recent ACS on top of with pericarditis complication. But if you suspect that there is an effusion by ultrasound, you will be very careful about the utilization of anticoagulation. And if there's an active ischemic component, you would want to use anticoagulation very cautiously and keep observing with serial echocardiograms whether the effusion is expanding or not. But the rule of thumb, if there's no active ischemic symptoms and it's just a pericardial effusion from a pericarditis purely pain complicating recent ACS, you do not want to use anticoagulation because of the risk of expansion and hemorrhagic transformation of this pericardial effusion.
Thank you.
Dr. لباس. Go ahead, Dr. لباس. أعطوا الميكروفون لدكتور لباس. ماشي.
Hello, Dr. Hani. Thank you so much for such a great presentation, and thank you for being with us today. Amazing lecture. Actually, I wanted to kind of touch base with you on the point that, cardiogenic shock, I agree with you. A nasty disease, and if you don't support and help pretty quick, you're not doing well, and you go down that spiral, and he's not doing well. Unfortunately, what would you do if you have limited resources, and we don't have the toys, like the Impella, the extracorporeal, the ECMO, and you're just stuck with a balloon pump?
So it's an excellent question. So it's a class 3 recommendation for lack of benefit from using balloon pump routinely for all comers in patients with acute MI complicated by cardiogenic shock. But there will be some selective use of balloon pump. Some of the selective use is when people have MI with MR complication, unloading with balloon pump works very well in these patients. Other instances, when you have recurrent ischemia and pending cardiogenic shock, a balloon pump can act as a very good anti-ischemic tool. It improves coronary perfusion. If you don't have other resources, balloon pump has no benefit routinely, but may have selective benefit in some selective patient population. So I would say on top of inotropes cautiously and vasopressors, it's okay in these instances, despite the lack of evidence to use balloon pump, because it's better than nothing. A balloon pump can increase your cardiac outputs between 0.5 to 0.9 liter per minute. So if a regular cardiac output is 4 to 5 liters per minute, you're only getting a 0.5 to 0.9 liter per minute. So it doesn't help with the cardiac output as much, but it certainly enhances coronary perfusion. It can unload slightly the heart, but in the absence of Impella or something more powerful, it may have selectively some benefit. So I would not discard it because of the lack of benefit. Remember, the lack of benefit was based on 600-700 patient study, and it was only in acute MI, by the way. So in non-acute MI cardiogenic shock, and I know this is not the topic of this lecture, but there may be there's not much evidence one way or the other, but I could see that there may be more use of balloon pump. So if you have no resources, on top of inotropes and vasopressors, selective use of balloon pump is not a bad idea to passivate the patient and transfer them for reperfusion therapy or definitive revascularization.
Thank you, Professor Hani, for this nice presentation, actually. I have a question concerning ACS or post-ACS. When can a patient, you think, safely resume his sexual activity and driving, and when he can return to work after MI?
That's an excellent. Rule of thumb: if you can climb up the stairs after an ACS, then you could go back slowly and gradually to resuming your sexual activity. Now, as you know, cardiac rehab now is a class 1 indication post MI, and even virtual rehab at home is a class 2A by our new guidelines. So I would suggest that the patients would go to cardiac rehab, and this is where a comprehensive cardiac rehab, exercise-based plus lifestyle intervention-based, can assess the exercise capacity of the patient. If the patient is back on track to resuming his usual physical activity during cardiac rehab, then he or she can resume sexual activity. I do not know that there is a number of days ascribed to this, but the rule of thumb, if they can climb up the stairs and can do acceptably well with phase 2 cardiac rehab, then they can go back to sexual activity. Excellent question.
Thank you very much.
Thank you.
Any more question? That's it. Thank you very much.
Thank you for the invite. Pleasure to be with you.
All right.
Thank you.
Hello? Great. Can we go into break now? Thank you.